Guess let's just go ahead and start. Good morning and good afternoon. Thank you and welcome to this breakout room where I will be presenting and sharing the experience of Breakthrough Action Communication for Health project and strengthening gender competency of health service providers, mainly frontline health workers through guided gender dialogues and exercises. As I go through the presentation, if you have any questions or thoughts, please hold them until the end of my presentation or write them in the chat box, and my colleague Olivia and I will do our best to capture and respond to them at the end. So just to give you a little bit of background about the project, the Communication for Breakthrough Action Ethiopia project is an integrated health communication project, mainly focusing on reproductive, maternal, and child health and malaria. The project has been designing and implementing multiple innovative SBC approaches, including mass media and mobile technology, and community engagement approaches to influence positive health behaviors and gender norms within our project areas. And enhancing the SBC and IPC capacity of health workers is also another main activity of the project, which also includes creating a platform for gender-related dialogue to enhance better understanding and better gender integration capacity among health service providers, which I will go into in a more deeper during this presentation. Please note that by health care workers, during my presentation, by healthcare workers, I mean mostly health extension workers and primary healthcare unit directors and health experts at district or Werda level. Some of the insights that we gathered from the literature reviews and during our consultative meetings that guided the design of these gender dialogues for health service providers were that the project's baseline survey showed that from 16 health behaviors, gender equitable norms were significantly associated with 10. And it clearly showed us that health outcomes are highly influenced by gender norms. We also know that women are usually the targets of our health system in our country's context, especially when it comes to issues around reproductive health, family planning, maternal and newborn child health. Men are less visited by and prioritized by our health extension workers. So men usually lack the knowledge and the information that they need to appropriately support their partners and their family's health. Health providers, like any other community members, have biases and judgments around gender, which also affects interaction between a client and a provider. However, even if there was no bias, evidence shows that health workers at different levels have limited understanding about gender and how to provide gender sensitive and transformative services. There's an overly focus on just improving health outcomes without addressing underlying gender barriers. So with these insights, we also acknowledge that a provider's behavior is influenced by multiple factors, including infrastructure, work overload, poor facilities and supplies that reduces and affects their efficiency and their interaction. But our focus for this particular intervention was mainly on stimulating thoughts and discussions around factors related with personal gender biases and nurturing gender transformative thinking in their personal and work life. So as part of an overarching training that we were giving for health service providers on SBC and interpersonal communication skills, we designed and implemented a 3-step exercise where first, service providers look in within themselves and explore their own attitudes towards gender. and then see the connection, how these gender roles and dynamics within a community and households affect health outcomes. And finally, on putting on a gender lens and being more cognizant to gender issues and how they can support communities and households to adopt equitable behaviors through SBC approaches and community engagements. So for the looking within step, we did a value clarification exercise where we come up with different statements and allow participants to agree or disagree to it, and make their cases to influence each other to change minds. So these are some of the statements that we use during the sessions, such as the head of family is the man, or a woman's most important role is to take care of her home and her family. In our family, there shouldn't be a distinction between a man's and a woman's role. So we just come up, depending on the contexts and level of and their level of understanding, we just come up with these statements, and which are mostly triggering and very lively, engaging, and sometimes leading to sensitive discussions. One of the main rules of the exercise, though, is that there are no right or wrong answers. We just encourage everyone to be as open as possible and just keep on probing and asking why they agree or disagree to the statement to nurture the discussion. Through the exercises, we were also able to see different perspectives of men and women, but most importantly, it allows participants to unpack and dig deeper and reflect, question their own personal beliefs and values around gender. Through the discussion, the facilitator deliberately highlights on gender and gender-related concepts, such as the difference between gender and sex, gender socialization, gender norms, and gender inequality. Usually this discussion, this first part of the discussion usually ends with some level of agreement that each and every one of us have our own gender beliefs, influenced by the society that we live in, that gender is not something to externalize, as we're all affected by it, and that gender norms can actually change over time. So the next step is seeing the connection between gender and health. So once they're done with the first exercise, the next step is seeing the connection. In groups, participants list out expected roles and responsibilities of men and women. What are the division of labor? Who does harvesting, who does the weeding, who does cooking, taking care of whose responsibility is taking care of the children, and who goes to the market, who makes the decision. These kinds of, they just list out these activities depending these roles and divisions of labors to within their specific context and among the communities they work with. This often helps participants to visualize the work burden, who has the decision-making power, who has access to the resources, which priorities are whose priorities, and how this could potentially be a barrier to health behavior and practices, including uptake of reproductive, maternal, and newborn child health services. Through this process, they also recognize, how gender issues are relevant to their own work as well. So once they've done that, they brainstorm on possibilities for change, what could be done differently, and what could be their role, who to engage with, and what could be their role in addressing gender inequitable behaviors. These are some quotes from the participants. The first one is a healthcare provider, a PhD director, who have said that it has helped me see the importance of understanding why women are not coming for services, regardless of their work we do. Healthy practices goes beyond knowledge. And at the end of the day, we have to ask why and come up with a solution. So he was in the process of really recognizing that, just really promoting health behaviors is just not enough unless we're addressing the underlying gender barriers. Another health extension worker from Oromia region also have shared her feedback on how she now better understand the need for husband's participation and how she can better engage with them during her house-to-house visits and her house-to-house visits. So the last part is using SBC approaches and tools for the health extension workers that would help them, put on their gender lens and support their service provision, whether it's during house-to-house visits or any community-wide events. One of the main tools that the project has provided them with to support their SBC work is a set of cue cards that supports them to have meaningful discussions with husbands and couples at different life stages. Within the different life stages, the cue cards come up with discussion questions and actionable messages that encourage and promotes couple communication and shared decision-making among families, in addition to sharing of household responsibilities and childcare. We've also provided them with a guide on how to engage other community influencers, especially religious leaders and other community leaders. The project also has also extended the gender dialogue through mass media, through our radio program. But most importantly, what we always emphasize, and we conclude the discussion with a very strong point that change starts from within before they actually start influencing others. So we ask them to come up with a pledge or one small doable action that they would do after leaving the session. So far, for the past year, we have had this session with more than 1,000 health extension workers and health providers. And I'll just quickly go over some of the lessons that we have learned from these sessions. One is interactive exercises rooted in personal experiences, provides opportunities for health providers to reflect on their own personal beliefs and values, and eventually see the relevance of gender to their work. We felt like we had really positive response and really strong engagement from the health extension workers, but we feel like there's a need for more comprehensive gender capacity, strengthening for service providers in general at different levels. We've also seen that using male gender champions to facilitate the discussion facilitates the change process, because like traditionally always gender issues are always led and discussions are led by women, and we make sure that during sessions that we identify male gender champions who lead the gender dialogues with the health providers. But at the same time, we've also feel like the cue cards and other SBCC tools that the project has provided reinforces their SBC and really supports health extension and health providers' efforts, their SBC efforts. And it's really important to provide, actionable messages and SBC tools to reinforce their work. However, although they go back with a lot of enthusiasm and energy and commitment to somehow contribute to gender transformative services, we feel like there has to be further follow-up on what change have actually been made on health providers, what kind of change has happened, and what kind of impact that has brought on health outcomes as well. So these were some of our learnings. If you have any questions or...
Esete, we had One question in the chat about which proportion or what proportion of healthcare workers in the program were women.
So, like I mentioned in the beginning, when I said healthcare providers, I mainly meant frontline health workers, health extension workers, who majority of whom are women. I think almost all of them are women, but healthcare, the PHCU directors are mostly men, which makes, and the district level health experts are also mostly men, but the majority of participants for these sessions were women themselves. Any questions, thoughts?
I'm wondering what kind of monitoring or follow-up you have been able to do to see how this may have changed any provider behaviors, or if that's still in process.
After we did the sessions, we've had multiple supportive supervision visits to health facilities and health posts to see how much of change has happened, and to see the level of use with regards to the Q cards and other SPCC tools. And so we've had supportive supervisions, but we also have regular quarterly review meetings with the healthcare providers to really talk about their challenge, how they've used the tools, and what kind of change they've made in their work, not just in their work, but in their personal life as well, in terms of gender. So the supportive supervision and mainly the quarterly review meetings were the main platforms to follow up.
So just following on that, thanks again, Esete. That was a great presentation. In those quarterly supportive supervision meetings or elsewhere, have you identified, sort of both sides of the story, the success stories, and at the same time, can you pinpoint any examples of sort of adaptive management that you've used those meetings to say, oh, we did this and now we have to do it this way, something like that?
So right now, the training has been conducted for the first half of the health extension workers for our project areas. So we're still capturing the learnings. We've seen that, like the sessions are very engaging, like people are very much interested in the discussion and the dialogues, but, like it has to be translated into an action. So we may need to revise some of our cue cards depending on the learnings from our review meetings. But so far, we're still in the process of really capturing the learnings and the experience of the health workers on how to implement the transformative approaches.
There's another question in the chat, which is, did you combine the HEWs with all other healthcare workers in the intervention? Wondering if conducting the dialogue separately helps in improving their communications with men in rural areas.
Yes, it was combined. Like I said, majority of them are the health extension workers. So maybe the health, the PHC director could be, per session, it could be 4 or 5 health PHC directors, which are mostly men. But somehow, yes, it may facilitate if they were separated, but it kind of also gave the discussion some flavor, because we were able to see different perspectives from men and women at the same time. There was no challenge, in terms of really opening up and really coming out and expressing their thoughts, because we didn't really see any challenge around that, but something that really came to my mind right now was that actually combining them kind of gave us, like to look at the gender issues different perspective, especially the value clarification exercise was always very hard because men may have different thoughts than women. So it was kind of more positive that they were merged.
And there's another question as well about what the gender norm change objectives were. You mentioned couple communication, but were there any other changes or objectives that you aimed for?
Yeah, so it was mainly aimed at, like nurturing couple communication, but at the same time, looking at the work burden women have in terms of household responsibilities and other engagements. So we wanted to show how men could better engage in household, if engaged better in household responsibilities and, like share other work, labor around the house and outside the house. Maybe they would have enough time because the workload really came out strong for women. From that is a barrier for women to access services, especially during their pregnancy or as parents of young children. So in addition to the couple communication, we also we're promoting for husbands or partners to be more participating in household responsibilities and childcare and family health as a whole. So that, RMSH, or when it comes to reproductive and maternal and child health, it's not always about women, but it's also about men. We wanted to highlight on that.
Elizabeth also just added a question. She said, you mentioned variations on personal views by gender. Did you find any variations on views that could be attributed to any particular ethnic groups within Ethiopia?
No, to be honest, no. We didn't go in that direction. Yes, it could be different from region to region. In some regions, the variation could be the male participants could be more open, but not on ethnic level. We didn't look into that. But in terms of region, yes, there was some variations, which we also try to adopt into our interventions.
Super. And just in the interest of time, I notice we have 15 minutes left here. I wonder if we want to transition to some of the discussion questions.
Mm-hmm. Yes. So if there are no additional questions, I would like to...
Esete, maybe I'll interrupt you for a moment. You said that you did take into account those regional variations. I'm just wondering if you could talk a little bit more about how you took those into account.
During the sessions, for instance, the regional variation is that sometimes certain cultures in terms of priorities and maybe more relevant to, for instance, for Benishangul Gums, where the practice is not really common for other regions. So we just wanted to make sure once they list out the division of labor, that's why we wanted to make the actionable messages and the way forward to come up based on each context, because each region had different, although there were some similarities, each region have their own specific gender issues. Gender relations could be different from one region to the other. So we just kind of, nurtured the discussion in a way that they bring that out and really identify who to engage with in the future to address those issues. And if the issues really come up, we also try to adapt it through our radio programs as well, into our stories, and really have them reflected, have the issues reflected in the different languages of our radio programs.
Thanks.
So if there are no additional questions, I would like to put out this discussion questions, so that we can all, learn from each other. We may not have enough time to actually go all over them, but I would also like to hear your thoughts around most promising SBC approaches to improving gender competency among health providers. Any learnings or insights from other projects that you worked on or heard about that you would like to share. So if you have any thoughts, any similar projects or activities that was done in other countries, or something you have heard before you want to reflect on, please. I encourage you.
Janine, did you want to say more about the tool that you're working on with Data for Impact?
Hi, sure. Yes, thank you. So Data for Impact has been working on developing a tool to assess gender competency in family planning providers, and it's really based on a training curriculum that HRH 2030 developed. I think one of their countries that they piloted their training in was Ethiopia, actually. And they have just released that. So that, and I think they're looking for feedback actually on the training curriculum. And so we have put together a tool that can be used. We have worked in Ghana so far to do some cognitive interviewing with providers to test the measures. And we're now moving to Uganda to do some similar work. And then we'll make the updates to the tool and hopefully release it next year. So that may be one thing that can be used to help monitor outcomes, before and after some of your SBC interventions. It could be also potentially used intermittently to see if, the outcomes are sustained over time as well. So thank you.
Great. Any thoughts, additional thoughts?
People can feel free to just come off mute and talk.
Maybe thoughts around also, I think you've raised a very important point. How do we really sustain the positive shifts? And, how do we monitor? And how do we actually really sustain? Maybe we can discuss about that. Any ideas around that?
Yeah, I was thinking, Esete, about the thought piece by Dr. Andrew Malhotra that I mentioned in the introduction. And she has some interesting perspectives on thinking through sort of how much we focus on through, for example, SBC channels, and how much we really need to do at the health system level as well. And they need to go more hand in hand. And so I think for that sustainability issue, I think shifts in health systems and the health system building blocks are really critical. I'm not a health system strengthening person, so I don't know all those blocks off the top of my head, but I know that the health workers are just one piece of the puzzle. And so, I think these kinds of efforts are essential and important to think through those sort of individual attitudes and behaviors. And that certainly impacts, interactions with clients and health outcomes. But I wonder, what more can we all as sort of health and public health workers and professionals could do to do that gender integration at the health system level, and what does that look like? So I think she was sort of really just making a call for us to think through the systemic factors that are at play and how that can limit, any efforts that we that we make at a more individual or a sort of clinic level.
Mm-hmm. Yeah. Yeah, I think that's a great point too, because, you know, just focusing on an individual level would not bring much of, it will contribute to the change process. But like you said, unless it's, you know, like constitutionalized or, you know, integrated at a system level, it may not be as impactful. As I've tried to share towards the beginning of the presentation, like the provider behavior is actually really influenced by different factors beyond their own biases and, you know, beyond their own beliefs. It's also about infrastructure. It's also about the management and other pieces that also need to come together to actually see the change. Yes, that's a great point, Joanna.
I see Gail has her hand up. Do you want to speak, Gail?
Joanna, yeah, I mean, I don't have any answers. I just have more questions. I think thinking about how norm change takes a long time to happen, and sort of thinking about the steps or the pathway to gender norm change. You know, we do know that norms are usually set and reinforced by what we call reference groups, which are usually, you know, a small group of people who really hold the power and get to kind of set the rules of the game, so to speak. And so knowing that about norm change in general, I'm just wondering, how do you break down some of these questions to really try and get to those who have the power to reset or shift the norm and the attitudes, you know, whether it's at the healthcare system level, as you were saying, or more broadly, culturally speaking, when you think about households and what you were saying earlier about women's workloads at home and things like this. I'm just wondering if you've kind of looked at that end of the sort of theory of change, so to speak, to figure out who's in these reference groups and how might we work with them to try and get big change. Thanks.
Yes, that's a great point too. Maybe I could bounce it back to other participants who would like to reflect on that. I don't want to take on all the...
Hi, this is Gudda. Can I say something?
Sure, Gudda.
Thank you very much. So in terms of the third point, particularly sustaining positive shift among service provider, one thing is the service providers are also from the community. So they are influenced by, they are part of the community, they are influenced by the gender norms in their areas. So that is one point, how we can, sustain those shifts is that is one point that we need to consider and a challenge. And the other thing is, in terms of my point, involving, the community itself as a driver of change. And also, they have to be, a kind of asking accountability for the healthcare system, so that if we include them in the system for gender shift or gender norms transformation, I think we'll be having a kind of sustained behavior among service providers. So engaging the community as they are part of the accountability system for the healthcare system, so that both the service provider and the community can, can have a kind of same goal, same attitude, knowledge, and practices. That is one point. And the other thing is gender, and one person mentions this one, gender by itself has, multifaceted kind of, influences. It is influenced by religion, it influenced by, maybe some tradition cultures in specific ethnic groups. So we need to go through those details to address specific context in specific ethnic groups that may be influenced by gender or some traditional practice and whatever. So in our society, the gender issues, there are a lot of gender issues which is ingrediented in the community. So it is hard to get the change immediately. So these are the points that I would like to mention in sustaining the positive shift. So these are the considerations. Thank you. Over to you.
Thank you, Guda. Yes, I think I agree with both, like engaging the community and really identifying who the reference groups are actually what are, because it could be different. It could be religious leaders, like you said. It could be rooted in religion. It could be rooted in culture, but really identifying who our reference groups are and really engaging them to, lead the change process is also another important point. But when it comes to changing cultures and, like norms, one thing that I would also like to emphasize is I always feel like we need to also acknowledge the positive ones, because not all gender norms are harmful or, I just feel like we just need to be more careful and cognizant and, identify those which could actually be identified with the community, identify those norms which can actually be fortified or which could be, with the dialogue, which ones could be reframed. So I think we should also use, be able to identify and I feel like we also need to use gender norms in a more positive way that just really is just aiming for changing. Any other thoughts? I'm sorry if I don't see your hands. For some reason, my screen, I don't see participants. So Olivia, you can continue helping me with if I'm missing on anyone who would like to speak.
Sure thing. I don't know that folks have been using the hand raise function. I think they're just coming off of mute, which is great.
Okay, great. Great.
We have about 30 seconds left. So I think any final thoughts, jump in, please, anyone.
Any final thoughts? If not, then I'll see you all in the main room. Thank you.
Thank you.
Thank you.
Thank you.
Toutes les activités communautaires qui se passent dans leur communauté quand elles sont au marché. Alors, le quiz au marché a pour focus, a pour cible les femmes vendeuses qui sont au marché, qui n'ont pas la chance d'être en contact avec les relais communautaires.
We spoke with sellers in the market, and we had a survey that we prepare in advance. And when they arrive to the market, there are different topics for health. And concerning, for example, family planning, we have different questions. We have about 5 to 6 questions. And we ask them in the market, and we ask everyone to act on them. So we go to the market with megaphones and we start asking the questions.
And Carol, we are now back in plenary. Everybody has returned from the breakout sessions. Thank you.
Welcome back, everyone. Thank you. I hope we didn't cut off our ERC discussion there too harshly, and you were able to wrap up some of your final questions and comments. we are now going to hear back from the note taker in each group who will just share one or two key takeaways from the discussion. I wonder if maybe we'll start with the DRC group.
Yes, I can start us off. So in our discussion, we didn't have a robust discussion, unfortunately, but we did a high-level summary of the work that's being done in DRC, and hopefully some of you caught the end. We talked about the project that they did in the market, where they collected information to understand some of the barriers women are having in society, especially when it comes to accessing family planning. And we talked about the parallels between social and gender norms and social behavior change, and how, if we use the two together, we can better understand how to create behavior change both in women and in men to improve access of family planning. Thank you.
Thank you, Kendra. And I'll turn to Olivia to share a couple of key takeaways from the Ethiopia discussion.
Sure, thanks, Joanna. So our group spent most of our time talking about our third question, which was how do we sustain positive shifts in providers' knowledge, attitudes, and practices to be more gender competent. We talked about the need to sort of further consider and how to integrate gender at the health systems level alongside interventions to shift HCP attitudes, knowledge, and practices. We also talked about how the gender norms influencing provider behavior are really coming from the community. And so the need to consider community gender norms as well when we're looking to shift how providers interact with clients from a gender perspective. We also talked about kind of hand in hand with that, how communities should be involved in driving the change process, and there need to be mechanisms in place for communities to hold health systems and providers accountable. We also talked about the importance of identifying specific reference groups and engaging them to lead in the change process as well, depending on who's most influential towards a specific group of people whose behaviors, knowledge, attitudes we're aiming to change around gender. We also talked about that changing norms really requires a long time horizon. So considering that that norms can be very entrenched and require time to change. And finally, the need to focus on identifying positive gender norms in addition to gender norms that we'd like to change, and to make sure that we're also focusing on the norms that are positive. Over.
Super, thank you. And let's hear from the Getting Practical group.
Pardon me.